Good afternoon, everyone. So the topic is intravitreal dexamethasone implant in epiretinal membrane surgeries. This is retrospective analysis. This is not moving. Yeah. So ERM is a fibrocellular proliferation over the ILM. Development has been an inflammatory process. Some people, recently there are studies which have started using intravitreal dexamethasone implant in patients undergoing vitrectomy, and there are studies which are supporting the above hypothesis. However, there is a limited number of studies analyzing the outcome of the combined procedure. So, as I told earlier, ERM is a non-vascularized fibrocellular contractile proliferation. It is comprised of RPE cells, fibroblasts, myofibroblasts, and it can lead to retinal edema, macular distortion, blood retinal barrier breakdown, and central vision loss or metamorphosia. So, managing ERMs, the gold standard has been parsplanar vitrectomy with epiretinal membrane peeling and ILM peeling. And meta-analysis of the ERM shows that the cystoid macular edema generally peaks at 4 to 6 weeks after the completion of the surgery. The studies have also shown that intravitreal steroids are capable of accelerating the intraretinal edema resorption and hastening the visual acuity, recovery. So this is Ozurdex is a stable and a long-term this thing to expedite the regression of retinal edema. Now coming to the aims and objectives, to evaluate the safety and efficacy of PPV membrane peeling with a DEX implant with no tamponade. It's only a saline tamponade, and we are not going to give the patient any positioning for the management of idiopathic ERMs. So the primary objective is to see the functional outcome as the improvement at the end of 1 month. And the secondary objective is anatomical outcome at the end of 1 month. So this was a single center retrospective analysis with a single surgeon, and the place of study was center for site, and the duration was the cases we had taken from the past 1 year, and study subjects were 27 patients. All of them underwent 25 gauge parsplanar vitrectomy, epiretinal membrane peeling, and intravitreal DEX implant. The methodology, we measured the preoperative BCVA, intraocular pressure, slit-lamp biomicroscopy, and fundus examination. This was repeated on POD1, post-op day 15 and post-op day 30. Coming to the demography, so in the 27 patients, we have a predominantly female population. 18 were female and 9 were male, and the mean age was around 57 years. And the preoperative evaluation, the logMAR BCVA was 0.5, and the central macular thickness was 312, and there were a total PVD in 18 patients and incomplete PVD in 9 patients. The procedure, we combined certain patients with cataract surgery. 12 patients underwent with the cataract surgery, and 15 patients went a standalone parsplanar vitrectomy. So post-op day 1, you can see that we are not miracle makers. We don't give POD1 recovery. You can see that there is an increase in the edema as well as a decrease in the vision on POD1, and that is natural because the patient has irritation, watering, redness, and so you won't be able to have a quick jump on POD1. But as you can see in this chart, from day 15 onwards, you can see that the central best corrected visual acuity average becomes better than the pre-op, and it progressively keeps increasing till the final follow-up of 3 months. And also the central macular thickness, you can see that there is a jump on POD1, but POD15, 1 month and final follow-up, you can see there is a massive reduction in the central macular thickness. Now coming to the results, there was a significant improvement in the BCVA from baseline. There was a significant improvement in the central macular thickness compared to the baseline. DEX implant helped hasten the recovery during the first month. No patient showed any IOP spikes. We have a very small subset of populations. Thankfully, none of them showed any secondary glaucoma because of DEX implant. 4 out of the 27 patients had drill, which was their pre-surgery, and that remained post-surgery, and those patients had a poor visual improvement post-surgery. 6 of the 27 patients, as you can see in this picture, there is a spongiform edema which developed POD15, and it still persisted. Even though the vision became 6/6 in this patient, you can see that there is a spongiform edema which was there, which is still persisting. We hypothesized due to the lack of tamponade, because there is no tamponade, there is nothing to press this edema back. And also there is a tractional stress over the retina which is causing this spongiform edema. Discussion, PPV with gas tamponade has stayed the standard for treatment of symptomatic ERMs. Gas tamponade restricts the quantification of early post-op recovery. Prone position has always been a bone of contention for every surgeon. We say 8 hours, the patient does 2 hours. So we don't know how much of a post-op prone position the patient is able to maintain. Aimed at resolving these drawbacks of conventional procedure, we can do it by saline tamponade and no positioning. These are some of the other studies. This is a study by Hostovsky et al., and they also did they had a smaller sample size compared to us, and they did a gas tamponade. This is Srivastava et al. In ARVO. They also did a gas tamponade, whereas ours is no gas tamponade. This is a study done, this is also saying that they had the gas tamponade in it. So the conclusion is that our analysis shows that simultaneous DEX implant with PPV could be done safely. DEX implant reduces the severity of post-op inflammation. Closing in saline tamponade provides a fast visual rehabilitation, and clear media enables us to quantify post-op recovery in a more laborious manner. And cumbersome prone position could be avoided, especially in elderly and patients who cannot maintain it for a longer period. So limitations of our study: there is no comparison group, and the follow period was short, and we need a randomized control trial to validate the data. These are the references. Thank you.
Just one question. In a vitrectomized eye, is any special technique of pushing the Ozurdex? Because it might injure the retina?
We did
Theoretically,
it in a saline
yes.
filled media. We did not do it in air. We did it in a saline. The saline, the velocity reduces as it goes through that. So we do not thankfully have any retinal.
In any case of detachment following?
Nothing.